Hello, and welcome to the Clinical Care Options Oncology podcast. I'm your host, Tim Quill. Today's episode features a discussion between Dr. Jean-Yves Blay of the Centre Lyon Berard in Lyon, France, and Dr. Robin Jones of the Royal Marsden Hospital and Institute of Cancer Research in London. The experts will be sharing their perspective on key data informing the use of tyrosine kinase inhibitors as monotherapy and in combination with other therapies for patients with soft tissue sarcoma and osteosarcoma. This episode is part of a larger educational program titled Current Topics in Oncology, a focus on tyrosine kinase inhibitors in solid tumors. If you haven't already, please take a moment to explore the other offerings of this program. For more information on Dr. Blay and Dr. Jones, along with a link to the complete program, including downloadable slide sets, please visit the show notes for this episode. Now let's get started and hear what the experts have to say about new and emerging treatment options for patients with sarcoma.
Hello, my name is Jean-Yves Blay. I'm a medical oncologist. I'm working in the Comprehensive Cancer Center in Lyon, France, and I'm working mainly on sarcoma.
And I'm Robin Jones, and I'm a medical oncologist at the Royal Marsden and Institute of Cancer Research in London, and again, working in sarcomas. Now, I'd like to start by asking Jean-Yves about the recent developments in the treatment of osteosarcoma, bearing in mind that the treatment of recurrent osteosarcoma has been particularly challenging, but there are some exciting trial data that we can discuss today.
Yes, absolutely. As you mentioned, the second-line treatment of sarcoma, second or third line for patients with advanced disease has been particularly challenging. In the last decades, basically, we made very, very little progresses. Recently, some interesting trials were reported demonstrating the activity of tyrosine kinase inhibitors, in particular those blocking VEGFR2 and other kinases, which have provided in a randomized setting quite a nice demonstration that these agents are active in relapsing osteosarcoma. There are two studies actually who explored that. First study reported was a SARC-024 study, which tested regorafenib versus no treatment in patients with osteosarcoma, showing an improvement in PFS. And the second study, which was the REGOBONE study, a phase 2 study, which was part of a bigger clinical study involving other bone sarcoma, which also demonstrated with a placebo control improvement in progression-free survival. In both cases, there was a crossover, so no significant improvement, but at least a proof of concept that tyrosine kinase inhibitors, which are blocking a variety of tyrosine kinases, are active in this group of disease indeed.
And the safety profile of regorafenib in these trials was very similar to previous reported adverse events with this drug.
Yes, absolutely. Actually, very comparable to what has been reported for the sarcoma, I would say, more than for carcinoma tumors such as colorectal cancer, actually. And food skin reaction, hypertension, nausea, diarrhea were among the most common side effects. But overall, that's a treatment which can be provided most often young population of patients with relatively good tolerance. And of course, here again, the adaptation of the dose is a key. Being adapted and flexible with the patient, depending on his or her side effect, is crucial in this case.
And in many ways, that leads on to further studies in terms of the potential for combinations, particularly in challenging sarcoma subtypes such as osteosarcoma. And I suppose that's one of the big questions. How do we move this forward? And are there ways that we can predict which patients will benefit from a particular drug or a particular tyrosine kinase inhibitor?
Yes, this has been a very challenging topic, hasn't it, in the recent years, trying to predict who are the patients responding. And there are some biomarkers, but they are not really black and white. It's more a correlation with serum level of cytokines, for instance, or molecular alteration, which are not really something which can be used to select patients. And it's true, as you rightly point out, that the question of combination is going to be addressed in this setting. Either combination with sequential administration of the drugs, first chemotherapies and maintenance with TKIs, or the combination of these TKIs with cytotoxics, which are also being tested. But I think trials are in progress, and probably different populations are going to provide different answer here. I mean, young patients, children are probably more capable to tolerate such combination as compared to older adults.
Yeah, and I think some of the trials of combination tyrosine kinase inhibitor treatment with checkpoint inhibitors, for instance, are very interesting and very interesting in specific sarcoma subtypes.
Yes, absolutely, and in bone and in soft tissue sarcoma as well. I mean, probably the most interesting results for such combination of VEGFR2 inhibitors, including regorafenib with PD-1 antibodies such as pembrolizumab, were provided, which indicates a substantial, important synergies with the two agents in tumors where the response rates have been relatively low using single agent. And that opens probably a brand new area of investigation. In particular, having in mind that the same tyrosine kinase inhibitors have some activity actually in soft tissue sarcoma, and that has been for a long period of time. What do you think, Robin?
Yeah, no, I agree. And I think for very rare sarcoma subtypes such as alveolar soft part sarcoma, the combination of an anti-angiogenic agent plus a checkpoint inhibitor has demonstrated really exciting results worthy of further exploration. So I think it's a very fruitful avenue of further exploration.
Yes, it's something where probably the understanding of the biological understanding of the disease will be guided by the therapeutic progresses, because we do not fully understand now why these tyrosine kinase inhibitors on one side and PD-1 antibodies on the other side are so active in these groups of patients, but also why the combination proved to be active. So maybe it's something which is related to the capacity of the tyrosine kinase inhibitors to block a negative feedback for the immune response. Well, it's really work in progress, right?
Yeah, and in many ways, this highlights the importance of offering patients with sarcomas the opportunity to participate in clinical trials, because that's really the only way that we're going to make improvements, particularly when there, as you say, there's a biological rationale for a trial, or for example, the osteosarcoma trials. Considering how rare the disease is, it's fantastic that there are two randomized trials that have been performed over the last few years, which is very good news indeed.
Which is very good news, and probably one of the reasons why there was not a single trial is that it's more simple administratively to have two trials on two sides of the Atlantic, but at the end we should merge the data and look at what is truly happening to a broader population of patients. You were mentioning the biomarkers. One biomarker which has always fascinated me is the histologic biomarker. I really wonder why adipocytic soft tissue sarcoma are so resistant to these tyrosine kinase inhibitors, because most of the studies which have been conducted go in this direction. They are resistant, whichever subtypes, by the way, of adipocytic sarcoma. Do you have an explanation on this observation, Robin?
I don't have a clear explanation. Having said that, anecdotally, there are occasional patients that benefit from, with advanced liposarcoma, that benefit from a tyrosine kinase inhibitor. And I suppose that highlights the need for better understanding of the biology of these diseases. But you're absolutely right, Jean-Yves. For instance, the results of the RIGO-SARC in terms of the 4 cohorts randomizing patients to receive regorafenib or placebo, clear benefit in terms of progression-free survival for the regorafenib arm in the Lyon myosarcoma cohort, in the synovial sarcoma cohort, and in the other heterogeneous sarcoma cohort, but no benefit in the liposarcoma cohort. So I think there really is need to try and better understand the biology of these diseases, but I do not have a clear answer to that right now. I was going to tease you. I was hoping that you do.
No, actually, we don't. Actually, I must say that the principal investigator of the RIGO-SARC study was probably not completely convinced, as we all are, that liposarcoma were resistant on the basis of the palette study, which selected only nonadipocytic sarcoma. But so wanted to have a separate arm with adipocytic sarcoma, and then, much to our deception, we observed that it was exactly the same, at least in this randomized study. Still, I think you're right. Some patients do derive benefit for a long period of time, and I think also in this study, which was conducted by our colleagues from the race with sunitinib and PD-1 antibody, there was some signals of activity in liposarcoma as well. So it may be more complex than what we know, and clearly we have to understand that better.
And I think, again, this highlights the need for a marker, predictive marker of benefit, regardless of histological subtype, which would be so useful in daily clinical practice. Again, there are other interesting data that have been presented this year in terms of the Nonadipocytic trial presented at ASCO. And again, that was a randomized trial, a randomized phase 3 trial versus dacarbazine with progression-free survival as the primary endpoint. And the trial met its primary endpoint with a median PFS of 2.89 months for Nonadipocytic versus 1.64 months for dacarbazine, with a hazard ratio of 0.449. But what's your take on that trial and how we can move this forward in synovial sarcoma, Jean-Yves?
A very, very nice trial, because it was really addressing a question that we had not addressed, which was a comparison with a treatment which was basically cytotoxics in this case. I think the benefit that has been observed for patients treated with Nonadipocytic is really substantial. I think that the median PFS is in a range of 6 months. That's something which is quite unusual. One thing which really struck me when I look at these studies, on top of the magnitude of the difference with a control arm, is that the shape of the curve for the different subtypes, namely alveolar, soft part, leiomyosarcoma, synovial sarcoma, was very different from that of other trials. And we know from the biochemical analysis that the kinase inhibitory profile of each individual of these TKIs are slightly different. For synovial sarcoma, the signal was strong, but probably not as strong as what was observed with Rego, and probably better than what was observed with pazopanib. Nobody really understands why. It may also be a selection of patients and no more than that. But this is really intriguing, and I think that the so-called off-target effects, what is a target actually in this tumor? That's something which is really challenging.
Yeah, agreed. And I think the really interesting thing about the synovial sarcoma and Nonadipocytic trial was the durable benefit that some patients received from the trial, with the progression-free survival at 12 months of 27% for the Nonadipocytic arm compared to 4% in the dacarbazine arm, which is very impressive. And again, if we could identify the cohort of patients that are most likely to benefit, it would be very, very useful for us in clinical practice.
Yeah, I think the work which has been done on trying to figure out who are the responders has not been successful, but still we should try harder. I still have in my clinic patients who were treated with Rego when the drug was a number, and with Pazo while the drug was a number. So for one, she received 15 years of pazopanib before stopping, and with an advanced disease, and the other one 7 years or more of regorafenib. Who are those patients? They look exactly the same as compared to other patients, and nobody really understands why.
But I suppose the good thing is that we have more options and more positive trial data to guide our treatment decisions.
Yes, and probably the next set of questions in view of this obvious activity of VEGFR2 inhibitors or multi-TKI is that these options may be used to try to do better even in first line. And there are some studies which are investigating these agents earlier in a maintenance setting for bone and soft tissue, in a randomized setting after stable disease or better with cytotoxic chemo. These are studies which are complicated always, right? The maintenance studies have not been that much successful in sarcoma, whether they are bone or soft tissue. What do you think, Robin?
Yes, I agree. But again, a very worthwhile question to ask, and could have, if the trials prove to be positive, could have implications in terms of the way we practice. I suppose in terms of discussing the trial or a maintenance trial with a patient, some patients are very keen to carry on with some form of treatment, whereas others do require a break. So there are different populations, I suppose, in terms of those who want to participate in that type of trial.
You are absolutely right. These studies are super selected. These patients, a lot of patients after having received cytotoxic chemotherapy, whether a single agent or combination, of course, do have the side effect, the cumulative side effect of cytotoxic, and some are quite reluctant to get maintenance treatment. And we probably select patients who are in better clinical condition, which is obviously an important selection bias. But still, we will see whether these studies prove to be successful.
But again, very important to support these trials and encourage participation so that we can move things forward.
And I think one of the message, as you pointed out a few minutes ago from these studies, is that it is feasible to do studies or sub-studies in selected histological subtypes or even molecular subtypes of sarcoma, including in a randomized setting, which I think we would not have thought it was possible some 10 years ago. And now studies from all around the world, show that the activity in alveolar soft part sarcoma, super rare entity, the same for synovial. There are studies in chordoma as well, this is amazing. It's possible to do that when we get united to do the clinical trials.
Agreed, and even a negative trial can provide a benchmark in a very rare disease, so that we can move forward with the design of future trials with prospective evidence to guide the best endpoint for future trials. So it's very positive that we've been able to do that.
Excellent. I think that there are still a lot of studies to be conducted. On top of the maintenance studies, probably future TKIs to be explored in selective histological subtypes are going to be questions to be addressed. I really think that you are right when you say that combination treatments with immunotherapy is certainly something which should be investigated further in view of all the different studies which were reported by the Spanish group, by the US group, by some other European groups, which are very much confirming the activity of combined treatment, which we obviously do not completely understand how they do work.
And in many ways, we, to use one of my favorite phrases, Jean-Yves, we need to do trials of subgroups of subtypes, just showing the heterogeneity of sarcomas and the challenges. And I particularly like that phrase of yours of subgroups of subtypes.
Subgroup of subtypes. Yeah, that's going to be our future. Even in sarcoma, where we thought we had already too many subsets, now we are fragmenting further.
Indeed.
We have some evidence of activity of TKIs in a lot of sarcoma subtypes, which were really underserved by the standard treatment. And I think that's really good news. And the path forward includes the integration of this treatment probably earlier in the different treatment phase. What do you think?
I agree. And trying to select the best patients and using these treatments in combination.
Thank you very much, Robin. It was a pleasure to discuss with you.
Thank you very much, Jean-Yves. Likewise.
Thank you very much, Dr. Blay and Dr. Jones, and thanks to you, the listeners, for joining us. As a reminder, to view the full program, Current Topics in Oncology, a focus on tyrosine kinase inhibitors in solid tumors, and to find our other podcast episodes, please click on the link in the show notes. As always, thanks for listening.